Let's introduce the last speaker of Symposium 2. He's Dr. N. Vikneswaran. Dr. N. Vikneswaran is a senior consultant in the Department of Gastroenterology and Hepatology at Singapore General Hospital. He earned his medical degree from the National University of Singapore in year 2000 and specialized accreditation in gastroenterology in year 2009. He completed his fellowships at Mayo Clinic and National Cancer Center Hospital, Japan, and focusing on endoscopic resections of early cancers, advancing imaging techniques, and management of benign esophageal disorders. Dr. Vikneswaran actively conducts research in therapeutic endoscopy, reflux and motility esophageal disorders, and colorectal cancers. He published numerous articles in peer-reviewed journals and book chapters and has reviewed for several GI journals. Now let's warmly welcome Dr. Vikneswaran to the podium. Today he will going to provide an overview on endoscopic treatment for gastrointestinal neoplasia. It's over to you, sir.
Thanks for your kind introduction and thanks for the invitation. It's always a pleasure to be back in Jaffna. So I'm Vignesh, and essentially today I'm going to talk about the endoscopic treatment of tumors in the GI tract. And there have been many advances in gastroenterology and specifically endoscopy over the last decade or so. And this would rank as amongst them as one of those things that has truly impacted the way we manage and treat our patients as compared to say 10, 20 years ago. So this is data from GloboCan that was just recently published. This is just to highlight the fact that digestive cancers actually contribute substantially to the global cancer burden. All right, and I'm sure you're familiar with this: esophageal, gastric, colorectal cancer, liver. And while the specific order and rank may vary from country to country, these cancers feature prominently. This is also the case in Singapore. And as I understand from our productive discussion yesterday morning, this also appears to be the case in Sri Lanka. All right. And what makes this particularly relevant is that at least 3 of these cancers, namely the colorectal, stomach, and esophageal cancers, are actually accessible via routine endoscopy. And this has several clinical implications. All right. So I'm sure you're all familiar with the idea of a polypectomy in the colon. All right. That really forms the cornerstone of all strategies of colorectal cancer prevention. All right. So in countries that practice colorectal cancer screening, you can undergo various screening strategies, stool testing, upfront colonoscopies, or CT colonographies. But really the cornerstone, it all converges on one idea, all right, which is basically to pick up this polyp, all right, and resect it. All right. And the thing about this polyp, if you notice, is that it looks like a mushroom sticking out into the lumen. All right. It's very obvious to see. And because it has got a neck, all right, all you need to do is to put a snare around it, tighten it, and cut it. And you've basically arrested this polyp and prevented it from becoming a cancer. All right. And conceptually speaking, this is the same idea that we have now extended towards the other parts of the GI tract that is accessible via routine endoscopy. And endoscopic treatment is applicable to neoplasia that is confined to the superficial layers of the intestinal wall, so long as it's not associated with any lymph node metastasis. All right. So the problem is that when we start looking at other parts of the GI tract, and to some extent this is also true in the colon, is that the polyps don't look like a mushroom as they typically do in the colon. All right. So they typically look more like a pancake in the stomach. All right. A flat lesion, just a subtle discoloration. All right. And this clearly creates a problem, 2 problems actually. One is you may miss it, you may not identify it, you may not detect it so easily because it blends with the rest of the landscape. And the other problem is that you can no longer, because it no longer has a neck, you can no longer use the routine snare technique to basically cut out the polyp. All right. So what that basically means is that you need to have newer ways or different ways of identifying these neoplastic lesions as well as treating them. All right. So, and ultimately all of this is based on the premise that cancer occurs through a multi-step cascade, all right, and where there's a long latent period in which there's a precancerous stage that can be identified and where interventions can be instituted to prevent its progression to cancer. All right. And this is a paradigm that has been largely established and accepted in the colon, and really that forms the basis of colorectal cancer screening because you can identify and remove polyps. This is also true in Barrett's esophagus because if you can identify patients with Barrett's esophagus and you survey them, you can find areas of dysplasia that may be treated, preventing progression to cancer. All right. Now what has happened is that this same concept has essentially been expanded to involve the stomach and the squamous esophagus. All right. We know that most gastric cancers occur from Helicobacter infection. All right. And this again occurs through a whole cascade of steps with an intermediate step of intestinal metaplasia that then progresses to dysplasia and cancer. All right. And likewise in the squamous esophagus, all right, whatever the injurious agents, we now recognize that there's an intervening step of squamous dysplasia. And essentially all the dark blue rectangles here, which are the dysplasias, are the targets for intervention to prevent cancer from advancing. All right, and this has given rise to diagnostic and treatment algorithms that have now been widely endorsed by multiple societies across many different countries and continents. All right, and I've just put up a summary of some of these societal guidelines just to make the point. So why do we want to do endoscopic treatment? Because in general, they're associated with good long-term outcomes, good survival outcomes. They are organ sparing. 20 years ago, if someone had esophageal high-grade dysplasia, you're looking at an esophagectomy. All right, now the patient can just simply get away with an endoscopic resection, which keeps the esophagus intact. All right, and this is especially important because many of these patients tend to be elderly. All right, and close to half of these patients have a concurrent cardiorespiratory comorbidity, which would often preclude a major surgery. All right, but of course, if you leave an organ that has demonstrated a propensity to develop a cancer behind, then there is a risk of recurrences happening, and indeed it does happen. But so long as the patient is subjected to endoscopic surveillance, the recurrences are picked up at a very early stage, which are usually amenable to repeat endoscopic treatment. All right, so the patient gets to keep the organ and have a good long-term outcome, but at the expense of repeated surveillance. So there's a whole potpourri of endoscopic treatment strategies out there, treatment methods out there. All right, but if I were to simplify, essentially there are three. One is endoscopic mucosal resection, which is something like shaving a tumor. The other is endoscopic submucosal dissection, which is essentially cutting a tumor with a knife. Right, and all of these are done endoscopically. And the third method is the ablation methods, which essentially involves burning the tumor, of which I think in the most relevant would be radiofrequency ablation, typically in the setting of Barrett's carcinoma. So what is endoscopic mucosal resection, or EMR? Essentially, we are trying to shave the tumor. So as I mentioned earlier, you've got a mushroom and you've got a pancake, and the problem with a pancake is that we can't use the techniques that we use with the mushroom. So the easiest way to solve this problem is to convert the pancake so that it looks like a mushroom, and that is in essence what an EMR does. All right, it converts a flat lesion into a polypoid configuration so as to facilitate snaring. All right, and there are many different ways that this is achieved. One is simply by injection. All right, if you look at the diagram on your bottom left-hand corner, all right, there's a tumor, but it's bulging out. All right, and the reason why it's bulging out is because there's been saline that has been injected into the submucosa to lift off the mucosal lesion away from the rest of the polyp, from the rest of the gut, so that now you have a nice little mushroom that facilitates snaring. The other way we do it is ligation. All right, which is the picture on the top. All right, so I'm sure you're familiar with Piles ligation or esophageal variceal ligation. So what essentially is done is that you basically you suck the blood vessel into a rubber band and you tie it up, all right, and then the treatment carries on. So and a similar principle applies in tumor resection, all right. You basically suck the flat tumor, all right, into the cap and deploy a rubber band so that you convert it into a polyp, into a mushroom, and then you use your typical polypectomy snares to cut it out, all right. And the last method, and this is typically used in the esophagus, all right. It's a method that's commonly used in the esophagus, all right, whether it's squamous or Barrett's. And the other method would be an underwater immersion technique. And essentially what we do is that we fill the lumen of the colon or the duodenum with water, all right. So what happens is that when you have a pancake-like polyp that is floating in the water, it essentially clumps up so that it now looks like a mushroom. And once you have something that's round and bulbar with a neck, it makes it much easier to cut it out, all right. So if you look at this picture here in a clockwise direction, this is a patient with a tumor seen on the top left-hand corner in someone with Barrett's esophagus. And what we typically do is that we inject saline. And the reason why we do this is basically to lift off the tumor layer, which is in the mucosa. All right, remember these are early cancers, right? So the tumor is confined to the mucosa. All right, so we inject into the submucosa so that we lift off the mucosal layer away from the rest of the muscle. And then we create a mushroom out of this. And then we cut it off. All right, and then you're left with an ulcer that heals in time. Endoscopic submucosal dissection basically involves cutting the tumor. So instead of converting the pancake into a mushroom, we leave the pancake as it is. But we just slice it with a knife. In this case, a knife that is inserted through the scope. All right, and this gives you better technical outcomes. But the problem is that because you're deploying a knife, the risk of complication tends to be a bit higher. All right, radiofrequency ablation is basically a technique by which we end up burning the tumor. And again, this is primarily used in Barrett's neoplasia. And this is a device that is used for ablation. And basically what it is it's a balloon that you put into the esophagus where the tumor is, and you blow it up, you inflate it so that it makes contact with the layer of the esophagus, and you burn the tumor. And basically what happens after that is that the necrotic layer of tissue basically sloughs off. You put the patient on PPI, and the mucosa reconstitutes itself. So that what was originally a Barrett's mucosa, as you see on the left, is replaced with a neosquamous mucosa, which you see on the right. And this is really what we hope to achieve in patients with Barrett's esophagus. All right. And radiofrequency ablation has been around for quite some time now. This was a pivotal study that came out in New England Journal about 15 years ago. A randomized controlled trial showing high rates of eradication of dysplasia and intestinal metaplasia, as well as reduced progression to cancer. And this has been largely affirmed by subsequent studies. Now, so we have great means to treat early cancers and precancerous lesions. But the problem with this is that we need to be able to identify these cases of early neoplasia. And the challenge that we face is that early neoplasia is superficial, all right? They're superficial lesions, all right? They don't give rise to symptoms. They don't bleed. They don't cause dysphagia, all right? They don't cause gastric outlet obstructions because they're so subtle. And because of this, it's challenging to detect, all right? And the other problem is that these lesions are asymptomatic, all right? So if you're going to identify patients with problems like this, all right, this will, in essence, entail the adoption of one or two of the following. All right, one is that you basically need to have the endoscopic imaging modalities that will allow you to better identify these lesions compared to the conventional methods by which we have been performing endoscopy in the past. The second issue is that you want to be able to identify an enriched target population that is at increased risk of developing these cancers so that you can spend more time looking at these patients or screening them for these interventions in a manner that is analogous to what is already being done for colorectal cancer prevention. All right, so let's just talk about the diagnostic imaging modality. Broadly speaking, there are two types. One is electronic, which basically means that the scope comes with certain optical settings where you just press a button and the lighting changes such that tumor looks different from normal tissue. All right. Then you have dye-based chromoendoscopy, which basically involves spraying the mucosa with some agent, all right, which reacts in a manner that allows you to differentiate tumor from normal tissue. All right. And this is a picture of someone with of the esophagus. So if you look at the image at the center, this is a routine white light image of an esophagus, all right, which looks pretty normal. You don't see any pancakes, you don't see any mushrooms, no ulcers, no cancers. But if you look at the picture on the bottom left, all right, this is narrowband imaging, which is a form of electronic chromoendoscopy. And basically what it does is that it filters the wavelength of light, all right, so that you get a different picture depending on whether it's normal or tumor. So if it's normal, it's green, and if it's tumor, it is dark brown and black. And basically what you can see in the center, this is a close-up view, is that what appears to be a normal esophagus actually shows a squamous dysplastic area as a brown patch. All right, so there is a tumor in this esophagus. And if you look at the picture on the right, all right, this is a case of chromoendoscopy. Basically what we do is that we spray the esophageal mucosa with Lugol's iodine. And what this does is that it stains the mucosa. But tumor is stained differentially compared to normal mucosa. All right, so that the tumorous area tend to be lightly stained. And what you can make out even from this suboptimal projection is that at 6 o'clock, all right, there's a flat white patch there, a lightly stained patch here, which essentially corresponds to a tumor. So if you had completed the examination with just routine white light endoscopy, you would have going to have missed this tumor, and this patient would have developed an advanced cancer maybe months or years down the road. All right. So Lugol's chromoendoscopy basically involves spraying iodine, all right, and essentially tumor stains differently from normal areas. It is sensitive, but it is not very specific. But it is very easy to perform because essentially you're just administering iodine. The problem with iodine is that it can cause a bit of chest pain, so we try not to give it too concentrated. And of course, if you aspirate it, you can give rise to aspiration pneumonitis. Narrowband imaging is one of several electronic imaging modalities, which is very easy to do. When you're performing endoscopy, all you need to do is to just press a button and maybe spend an additional 10 to 20 seconds or 30 seconds of examination time to look at the esophagus in the vast majority of the patients. All right, and if you see a brown area, then you spend additional time to characterize it to determine if it's a tumor or not. And this gives you real-time diagnosis. I think for those of us who were discussing yesterday, there was a question asked about how you identify squamous dysplasia. All right, I mean, it is ultimately a histological diagnosis. But now you have the endoscopic means of being able to identify this confidently, real-time during the procedure itself, that then allows you to make a clinical decision as to what you are able to do next. All right. Now, the biggest drawback with this is cost. But having said that, most of the newer generation endoscopes that are now currently available for routine use actually incorporate one or the other electronic chroma-endoscopic imaging modalities as a routine. All right. This is one of my patients that I scoped not too long ago. A man in his 50s who had surgery for achalasia about 30, 40 years ago. And he had an endoscopy done for an unrelated indication. But because of the fact that he had achalasia, which is known to increase the risk of squamous cell carcinoma, all right, I made it a point to look at the esophagus. And if you look at the image on the center, it's all green as you'd expect in the esophagus. But if you look at the image on the right, because it projects better, you see that there are brown patches. And it's not just one patch, but there are multiple patches, right? Because sometimes, in many of these patients, the dysplasia may be multifocal, all right? And keeping in mind that squamous cell carcinoma is a field effect, this is the picture on the left, all right? We make it a point to routinely examine the laryngopharynx when we are going in, even though we are not experts in that part of the body. And what you notice is that, again, there's another abnormal area over the arytenoid, all right, suggestive of a synchronous area. All right, so this patient will obviously require further treatment. All right, and you've picked this up before it has become a cancer. This is another patient with Barrett's esophagus, all right, undergoing surveillance. And the picture on the left is again a narrowband imaging image. And again, in this case, because it's Barrett's, it's a bit different. The dark areas actually is the normal Barrett's mucosa. But you look at the center and you see this brown patch. And this is basically a dysplastic area, tumor. And if you look at the picture in the center, it doesn't project so well, but essentially what we've done is chroma-endoscopy. But in this case, it's even more straightforward. We use acetic acid, which goes by the scientific name of vinegar. And many hospitals actually purchase this from the supermarket. And we instill this over the esophagus. And what you notice is that there's an unstained area at 12 o'clock, which is not as white as the rest of the mucosa. And this was targeted, and this essentially corresponds to the image on the left. And this was targeted for EMR, all right? And essentially the histology came back as low-grade dysplasia. And if you look on the picture on the right, what we have basically done is that we have cut out the tumor, all right? But we've left the esophagus intact. And this is a procedure that can be done either as an outpatient or as an overnight stay, all right, under conscious sedation. And the patient goes home and keeps his esophagus intact. So that's the value in terms of having the capabilities to identify these findings. Of course, then the next question is, should you then be screening for target populations who may be at heightened risk? I think this is a concept that is well established in the colon. I think in Barrett's esophagus, screening still remains contentious even in a high prevalence country, but surveillance less so. I think surveillance is pretty much a standard of care. For the stomach, I think we now have emerging evidence to suggest that surveillance may be considered in a subset of patients. I'll show you subsequent slide. And then squamous dysplasia. This was a recent guideline that we have published in Singapore based on a large multi-center prospective cohort study looking at over 3,000 patients with intestinal metaplasia. And what the study demonstrated was that the risk of gastric cancer was associated with several risk factors which could be used to make a model. So depending on the severity of intestinal metaplasia, whether the patient had a first-degree relative with stomach cancer, if the patient was a smoker, or if the patient had a persistent H. pylori infection, these were factors that were associated with a heightened risk of gastric cancer. And depending on the number and type of risk factors that the patient had, we subsequently were able to come up with surveillance guidelines as to who needs to be surveyed and at what point in time. I think people have attempted to do a similar exercise for the squamous esophagus, but this is a bit more contentious because the quality of evidence still remains poor. And most of the target groups that have been identified only constitute a small minority of patients who actually go on to develop squamous cancer. Right. But I think the larger point that I want to make here, and I would argue that this is probably the most important point, is that even in countries and societies that practice large-scale population-based endoscopic screening, the majority of endoscopically resectable cases are detected on diagnostic endoscopy performed for unrelated indications. What do I mean by this? Let me give you an example. For example, in Japan, all right, they have a population-based screening program for gastric cancer because it's highly prevalent there. But if you look at the experience that's been published from referral centers, the vast majority of cases that are referred for endoscopic resection are actually picked up not on these screening programs, but for the routine diagnostic endoscopies that are performed by doctors for all kinds of indications that may or may not be relevant to the lesion that has been picked up. All right, so if you perform a scope for someone who said iron deficiency anemia, all right, and the examination is normal, and that answers your question with regards to iron deficiency anemia, but if you miss the lesion that is already there, then that represents a missed opportunity. All right, and that's the reason why in endoscopy, now we say that every endoscopic examination is an opportunity to look for cancer. Even though that may not be the reason why you're performing the examination, but because you're performing an invasive procedure that has a means that allows you to identify these cases, the effort should be made to actually identify this. All right, and this is something that we have tried to look at in the Jaffna population with our friends in Jaffna Teaching Hospital and the university. All right, I'm unable to share the findings with you because they've yet to be presented. But suffice to say that when we looked at our patients in the hospital here, we have identified patients with cancer precursor lesions, which are amenable to endoscopic treatment. So the question that I have for you is that for those of you who practice endoscopies in your various practice settings, all right, you may be doing a competent exam in terms of addressing the patient problem, but are you missing the opportunity to identify a lesion which, if treated, would prevent a patient from developing cancer shortly thereafter? All right, so to conclude, I think endoscopic treatment of early GI neoplasia is associated with good long-term outcomes, and its detection is facilitated by endoscopic imaging. Screening may be considered in selected high-risk populations, but I think the most important thing is that it's a purposeful examination during routine diagnostic endoscopy that enables the detection of early GI neoplasia. All right, and I want to take this opportunity to thank our friends in the hospital as well as the university, all right, for our continued collaboration. So thanks to Professor Suren and Dr. Satyamurthy and everyone. And with that, I conclude.